Okay, g'day and welcome back to the BroomeDocs and the first 10 AM Journal Club for the month of May 2024. Those of you who are regular listeners may realise that these are becoming a little bit more frequent. So Justin and I have made a concerted effort to try and bring these to you every month, or at least every 6 weeks, but trying to do it as monthly as we possibly can, and maybe making them a little bit shorter for the listeners that suffer through our banter and our ramblings. So, Justin, g'day, mate, and welcome back to the podcast once again. Always a pleasure to chat.
I get so jealous when you say good day. I wish I had a Canadian way of saying hello to start this podcast. Like you're so prototypically Australian, and I got nothing. I don't know how to say good day in Canadian. But anyway, good to see you. Welcome. Glad to be back.
Hello. I don't know how do Canadians talk.
Sorry. Yes, hello. Sorry, I'm here. Yes, hello. Something along those lines, I believe, it's supposed to be Canadian.
Well, actually, while we're on the topic of people that apologise a lot when they speak, I'd love to give a shout out to a couple of my local colleagues who I know are listeners to this podcast. And I promised them I wouldn't mention their names on air. So g'day to my good mate, Dr. Dave Forster, who has been on this podcast back in the day, maybe about 10 years ago, actually. And he speaks a lot like a Canadian. He apologises profusely at the end of each sentence. And also to my mate, Sean Fernandez, who has been a real good help and a great mate up here in Broome. So g'day, guys, and hope you're enjoying life in Broome coming into the lovely dry season. We've had some great sunsets lately, so if you've ever had a chance to go to Broome, this is the time of year to be here. April is my favourite, or May, yeah.
And I heard you right. You said you promised them not to say their names on the podcast right before launching into that. Yeah, good. Can't be deleted now. There's no editing in podcasts, so
there's no editing of this podcast, as you well know. Anyway, now just before we came on air, just as a little thought experiment, because Justin's obviously the father of a small child and doesn't get much sleep, and he wakes up early in the morning to record this podcast with me late at night over here in Australia. So I sent him an image, a couple of images actually, of a classic Broome case, just to see if he could do a spot diagnosis from the other side of the world. What do you reckon, mate? Had a chance to have a look at that picture? There's a hand and a foot. What do you reckon?
Yeah, it's a little problematic. I told you I didn't get any sleep last night. I didn't tell you it was mostly because my kid, I think, has bad eczema, but was up with like some kind of rash and scratching all night long. So it freaked me out by sending me a rash. I get 10 seconds to look at a random rash on my screen, and I put on the spot. I love it. I'll tell you, I have not seen this, and I am very bad at dermatology. And there's really only two things that come to my mind. I'm seeing rash on the palms, and it's a weird rash that I have not seen the looks of. So. Diagnosis number one, if I saw this in Toronto, would be, that's got to be syphilis. It's on the palms, and it's something I haven't seen very often. But I've also heard of, you're an old sheep farmer. There's some kind of weird like Orphe thing. I think that's down when you're in Perth and not up in the Broome. So I have to do syphilis without me knowing anything else about this, and then I'm moving on.
Perfect. You're a genius. There you go. Secondary syphilis.
I'm going to Google Orphe because I've never actually seen it, but I thought you might have put me on the spot.
I don't think it looks like Orphe. Yeah, it definitely doesn't look like Orphe. Okay, no. I'll chuck it in the show
spot on the finger.
Yeah, there we go. So yeah, hands and palms and soles. It's got to be syphilis in the right context. And unfortunately, in Broome, in the Kimberley part of Australia, there's an outbreak of this at the moment. So we're seeing this not infrequently, and it's unfortunately a very preventable disease that has a lot of obviously vertical and horizontal morbidity associated with it. So. Something that people just need to be aware of. I love my job, Justin. The other day, I turned up to work. I got there at 7 o'clock. I thrombolized a STEMI at 7:05. I resuscitated a neonate about a 3-month-old at about 10 o'clock in the morning. I saw this person with secondary syphilis at lunchtime. I did an emergency Caesar. I did an epidural at about 4 in the afternoon, and then that converted to an emergency Caesar at about 8 p.m. at night. So it's just an amazing job. And if anyone is interested in rural generalism, I'm more than happy to chat to you about it over email or whatever you want. So just get in touch, because it is just an amazing job. You get to use all your skills every day, and it's never boring. So big shout out there for emergency and rural generalism, because it's just such a cool job.
Yeah, I think that's the key. My best shifts ever by far have always been in the smaller rural spots that I've worked because you get to do a little bit of everything. My most stressful shifts have also been in the rural setting because there's no backup and nothing else. But it really takes the focus onto clinical medicine as compared to like I like working where I work, but the focus is moving meat. There's more than 300 patients presenting a day, and you just got to see patients and fly through it. And that just ain't the case when you're working rural. You get a little more time to do real good medicine. I like that.
Yep, absolutely. The country's where it's at, if you ask me. So I'm a bit
Yeah.
biased, but hey. Anyway, enough ramblings. Should we jump on into the meat of this show?
Yeah, I guess if people are truly interested in evidence-based medicine and they put up with us this long, we can jump in. I'm pretty interested in this first paper. I'm interested to see what your takes are, but this is a prospective study looking at the brain injury guidelines that I'd never heard of before. So this is in the Journal of Trauma and Acute Care Surgery 2022. Lead author is Joseph, and the paper is validating the brain injury guidelines, results of an American Association of Surgery of Trauma prospective multi-institutional trial. That's a lot of words. I don't know if you've ever seen these guidelines before. Basically, there's three categories. There's mild, moderate, and severe. They call them big 1, big 2, and big 3. I'm not going to try to go through their whole table. We'll put it in the show notes if you're interested in the exact criteria. But basically, low risk is going to have a very small bleed and no neurologic involvement, no antiplatelet medications, and no intoxications. And so in the low risk group, interestingly, they're suggesting 6-hour observation in the emergency department and send these patients home, which is very different from anything that it's ever done in Canada. If you find a brain bleed on the CT scan, the moderate risk, they're saying we don't need to call neurosurgery. We don't even need a repeat CT scan in the moderate risk, but admit them for 24 hours just to watch. And then the high risk group gets everybody. Repeat a CT, admit them, call neurosurgery. So they're trying to decrease resource use, which I think makes sense. There's two schools of thought on this. There's the look, consultants are on call. They're on call. They should take our calls and shut up about it. But then the other side of it is look, I don't call orthopedics about every single fracture, but for some reason we still call neurosurgery about every single bleed. But I already know the outcome. I know that it's not neurosurgical before I call them, and for some reason we just do it to cover our own asses. And I'm not sure that's a good use of my time, and I know it's not a good use of their time. And so I understand in a busy center like that, like Toronto, they're always exhausted, and so. It doesn't excuse unprofessional behavior, no, but do I understand why people are a little bit snippy on the other end of the call when they're just taking needless phone calls at all times? So did these work, I guess, is the real question. So this is a observational trial that looked at all that. And I guess it depends on how you define working. I think they work pretty well. So the moderate and low risk categories had zero need for neurosurgery, which seems to support the idea that you don't need to call neurosurgery if there are zero neurosurgical cases. Whereas the high risk category is high risk. 16% deteriorated clinically, 20% had worsening on a repeat CT scan, and 20% had neurosurgical intervention. So high risk is definitely high risk. The two major issues are there enough patients? So in the low risk group, can we really say that low risk is low risk enough to just send them home from hospital? This paper is weird. I've never seen a paper that didn't present any statistics at all. So there's no 95% confidence intervals. And really it's the low end of the 95 or the high end of the 95% confidence interval that we really care about. We don't care that there's zero risk for neurosurgery. We care about, is it 0 to 10% or is it 0 to 1%? Those are two very different things. And then in the moderate risk group, they tell us not to repeat the CT scan, but there was a reasonable risk. 7% when you redid their CT scan looked worse. Now, flip side of that is none of them needed neurosurgery, so who cares what the CT scan looks like? That's not a patient-oriented outcome, but I don't know how many people are going to be comfortable not repeating a CT scan. One extra CT scan is somebody with a known bleed if almost 1 in 10 are looking worse on repeat CT scans. So I think these have a lot of promise. I think we should be doing less in these patients, but I'm not sure if following these exact guidelines makes sense. So that was a pretty long-winded bit of talking by me. What do you thought? Would these be things you would work at, especially up in Broome, where you're got to go long distances with patients? What are you doing with these patients?
Yeah, it's tricky, and certainly the culture in my part of the world is that if you've done a CT and it actually shows something, like if it's not plumb normal and they've got a little bleed or they've got something else going on, then we definitely would be speaking to neurosurgeons just to get a plan and more just to, I guess, establish that relationship so that they know that the patient's there and that they're on their radar. And like you say, I'd much rather fly these patients from Broome when they're not too bad, rather than wait until they're deteriorating at the 6 hour mark or the repeat CT and then have a disaster on my hands. So it's tricky. I think probably the most impressive stat that I took away from this is that if they've got 2,000 patients in this trial who all had a bleed on their CT. And usually when we do these risk assessment scores, like, the mild ones are sort of 2/3 and the moderate ones are most of the rest, and then the severe ones are up the top end, it's just a few percent. Whereas this is not the case in this cohort. In the baseline stat is that 1,400 out of the 2,000 were with the big three. So, it's 2/3 of the patients basically were in the bad group. So depends a bit on your cohort. Like I tend to deal with a pretty young group of patients who probably have a lot more intoxication but don't have all those other medical things, and they're probably slightly bouncier brains. So those are the ones that probably do better. It's really difficult to say one way or the other, but once I've seen a bleed on a CT, it's difficult not to at least admit that patient and watch them. And I think there's very little harm in admitting a patient and watching them for overnight or whatever it happens to be, because I think the idea of sending someone home at the 6 hour mark is great if you're in a big ED that's trying to churn through 150 patients a day and you're trying to get rid of people out the door as fast as possible. But I think if you're in a small place and you don't have the backup, then admitting everyone seems like the right thing to do once you've got a CT showing something. Because, there's not much downside to that. Do we need to repeat CTs on all these people? I would be guided by the neurosurgeons on that. And obviously, there's a lot of nuance that goes into this. All of these risk scores tell you a bit about the patient. They don't include a lot of those subtle variables that we sort of get in our spidey sense. So the alcoholic that's had their 17th fall in that particular 6-month period, I'm going to be more concerned about that person than I am about the alcoholic 20-year-old that's just taken one hit to the head. That's not going to bother me quite so much. So I think you still need to use your nuance. And as we've said maybe 100 times on this podcast, clinical decision rules are guides. They're not actually telling you what to do. They're just useful for baseline numbers, really.
Yeah, I think there's a couple levels to this. I'm really interested in this going forward, because I think this data is a good indication that, we probably are overdoing things. That wouldn't surprise me at all, that we're overly cautious, because we're overly cautious everywhere. I don't think this data is enough to jump in with these exact guidelines clinically. I'm really fascinated because I think these will have a small benefit, and I'm going to try to get a modified version of these implemented where I work. But the benefit where I work, where I'm transferring a patient, 30 minutes down the line or calling somebody, is not a big thing. Long term, and if we could really prove that there's zero risk patients out there, saving a long plane flight, saving big travel, these probably do have a bigger role potentially, or expediting transfer, trying to identify the right patients to make phone calls about and airplane trips about makes a lot of sense. For me, the modified version that I have in my head, low risk, I agree. I'm not sending them home at 6 hours, but 24 hours of observation without a CT scan and without a necessary call to neurosurgery makes some sense to me. In the middle group, 24 hours of observation with a repeat CT scan if there's a 7% risk of it getting better, and then only calling neurosurgery if they get worse or the CT scan looks worse makes sense to me. And then, obviously the high risk is going to get everything. But what I think I'm going to try to get implemented, which seems like it makes sense to me, is just an email list to our neurosurgeons the next morning. So rather than calling every single one of them, just send them an email. Here are the patients. Have a look at the CT scans. If you think we're doing something wrong with just observing them, you can give us a call. And that way you don't have to phone call everybody. You don't have to wake them up. This isn't a 2 a.m. thing. So that way we will still have the neurosurgeons involved, but in a relaxed way on their own time, rather than forcing them to answer the phone call. Who knows what they're up to. So I think there's some promise for this going forward. If you're out there by yourself, I think it's worth talking to the neurosurgeons about, saying, hey, what do you like? It's actually not the neurosurgeons who are going to be the ones who are a hard sell where I work, though, because they don't want to be involved in these low risk patients. But it's the internal medicine doctors or the hospitalists who these patients are going to be admitted under. If it was my decision, I would already not call neurosurgery, but I'm not the person admitting these patients. So it is going to be a complex hospital politics, but I think it's worth working on a little bit to smooth our shifts and to make neurosurgery's life a little bit easier. But I don't know. We'll see how it goes.
Yeah, absolutely. I think if I was a neurosurgeon and I was working in a big, busy hospital, I would want this guideline to be well known to all the emergency and internal folks, because that way you could avoid a lot of work, and I imagine that there's a lot of variability from one neurosurgeon to the other. So this may be one way of sort of standardizing practice and getting sort of good advice. But I don't work in your system, so I'm not entirely sure. But it would seem like a good template to sit down and have that discussion in your system.
Yeah, I think we got to be careful. Like, it's not about avoiding work. Patients should always get the best advice from whoever it is. But look, again, the example of ophthalmology or the example of ortho, I do not call them in the middle of the night for every single thing. We have great ortho follow-up. They check all those extra, because if I find a fracture, it's not like they go home without nothing. Although I guess finger fractures and stuff like that go back to the family doctor. But for the most part, they're still involved, but they don't have to be involved real time. And I think that's a model to think about. But to me, this is like, people got really angry at me. If you want to see the fun of social media, that Reddit got really, really, really angry about this paper, whereas Twitter loved it. So that's fascinating. But I think it's a matter of adopting it to your local practice, which is the art of all evidence-based medicine. Is you got to know the evidence, but then you got to think about how it actually applies locally, and then talk to everybody. So I think this is a paper that's worth exploring locally, no matter where you are, and then trying to adapt to your own local practices.
Cool.
Whereas the next paper, I'm not sure is worth adapting to your local practice, but I really wanted to see how you reacted to this one. So I'll let you take this one. This is great.
All right. So this next paper is entitled "A New Technique for Reduction of Posteriorly Dislocated Hip Joint" in the American Journal of Emergency Medicine from 2023. The lead author is Zwank. And this is basically case series of 5 cases, which, take that what you will. So we've all had the struggle of trying to put a posteriorly dislocated hip joint back in. In little old ladies, it's not too hard, but in big, heavy, sort of 70-kilogram legs, that can be quite a tricky thing to do. And we've all had those sweaty moments in the ED where we're standing on a bed, hoiking someone's knee up into the air, trying to get them back in. And it's a bit like shoulder dislocations. There's like 50 described techniques for how to do this, and everyone has their own way of doing it. The Captain Morgan is your favorite, I understand. Is it the Captain Morgan Stern or just the Captain Morgan?
Yeah, I tried to get it adjusted in the resident's mind, but yeah. I mean, I think residents like rum more than me still, so it'll be the Captain Morgan for a long time.
So to describe exactly what this group of doctors in an emergency department have done. Essentially, they've taken a patient hoist machine, so the hoist that we use for moving sort of patients that can't lift themselves off toilets or beds, that nurses use all the time on the wards and inpatient teams. Have the big strap that goes under their backside and lifts them while they hold onto it. It's a hydraulic lift, essentially, which is used for patient care. And they lay the patient supine on the bed, strap them in with like a seatbelt to the bed, and then put the hoist strap under the popliteal fossa of the knee, and then crank up the hydraulic lift to pull that hip joint northwards towards the ceiling and try and reduce the hip. Now, there are a few problems with this, Justin. As you pointed out in your write-up, like, not really sure we know exactly how much force this thing is doing, and the big difference between a machine doing it and you just doing it with your hands is you get that immediate biofeedback of, I can feel that joint moving, or I can feel the bone cracking, or I can feel bruising happening. You know exactly how much force you're applying to the patient when you've got your hand under their knee pit or under your arm. So it's I don't like the idea of losing that biofeedback of that, as knowing exactly how much pressure I'm putting in. And I do like the idea, though, that this, I'm sure that there's doctors around the world that have injured their backs by trying to do this, and it can be maybe seen as a good thing for occupational health and safety. So I think I can see the upsides of this, but I can really see the downsides. And we talked about MacGyvering on this podcast maybe about 5 years ago. And it was more in the anesthetic context where people were taking random pieces of hospital kit to MacGyver things. And it's just not a good idea. Like anything that's not specifically designed for purpose in medicine, we should really think about whether we're using it correctly. And if we do cause harm to a patient, is that really the right thing to do?
But yeah, one of my favorite papers we've ever done is that Laura Duggan paper, and yeah, being really, really cautious about MacGyvering things. But I do think the flip side is, like, innovation is important, and like just ramming away with our hands in an era where, we have technology to help us is not unreasonable. So I do see both sides of this, and putting healthcare workers at risk and jumping up on the bed and hurting yourself doesn't make sense either. So I think, I'm not trying to write it off, but when I saw the video, when I saw the pictures, my initial instinct was this worries me. And I think I'm maybe stealing your thunder, but I have some ideas from this, and there may be safer ways to do it. The evidence-based medicine thing, I'll throw out. This is 5 cases, and it was only successful in 4. And my success rate is at least 80% when I'm doing hits. So I'm not sure that even sounds all that good. And obviously, a case series of 5 is not great evidence-based medicine. So I threw this in there for a discussion about MacGyvering more than anything else. But yeah, I have my own way that I might use a version of this in the future, but I'm interested in yours. You go right ahead.
Yeah, so if I was going to do this with a hydraulic lift, what I would do is I would crank the bed up to a height that's comfortable for me, so it might be up to waist height or whatever. So the actual bed lift, not the hydraulic thing. Then I would bring the hydraulic lift in the popliteal fossa and just lift the leg up so it's just being held up against gravity. Because I'm not really comfortable with using a hydraulic lift, but I'm very comfortable with using the electronic bed control. And then just bring the bed down slowly, maybe an inch or so at a time, with my hands bracing the patient's hip, so that if I feel something that I don't like, I could let them go and they'd get pulled up, or just slowly bring the bed down an inch at a time. Because I think that way the patient's not strapped to the bed, and I've got that biofeedback because I can feel what's going on in their hip, and then I can just gently rotate their knee back and forth to try and get it to adduct or abduct into that position where I think it's going to pop back in. So that's the way I would play it. So I've got that biofeedback in my hands too. I don't like the idea of having the patient fixed at 2 points on both ends of a long bone that's potentially going to crack in an old person. That's just my feeling.
Yeah. 100%. The part of this picture, and I think people want to look at the show notes, or if you're watching on YouTube, I'll actually try to cut in the video here. But the part that bothers me is the strap. The strap to the bed is a problem. So I could see using the hydraulic to lift the leg and get them perfectly positioned, and then using my hands. I like your idea of just lowering the stretcher, or just literally using my hands to push down on the pelvis. So instead of the current technique, which is pulling up on the leg, having the leg positioned with the hydraulic lift and then pushing down on the pelvis as my primary source. But I just don't like them being strapped in two points. That seems like a lot to me. But I like the innovation of potentially using the lift to do the hard part, and then us doing the easier part of manipulating the pelvis. If you just remove that strap around the stretcher, this whole thing feels a little bit better to me. Yeah. So as a backup idea in those patients who are really difficult, it seems fine. Honestly, I said it in my post, but most of the time, this is really about anesthesia. And I guess there are some patients who are high risk, but if you can get good relaxation on the muscles, this is generally not that hard of a procedure. And if it's that hard, something is off. And I don't mind involving orthopedics in the, 1 in 20 that I actually can't accomplish with my normal techniques, would be my current thought. But that also might depend a little bit on where you are and how hard it is to get some added help from orthopedics. Because where I am, if it's that 1 in 20 really difficult one, the trip upstairs in the same hospital to orthopedics does not seem like a big deal. If you're having a longer trip than that this having some more backup techniques may make sense.
Yeah. Well, my orthopedic surgeons are only like 2,000 kilometers away, but I do know a couple of big security guards that are quite good at leaning on people. So I have backup. Let's face it, orthopedics are the security guards of the medical world when it comes down to it.
I assume we have no orthopedics listening to our podcast, so we're probably okay saying whatever the heck we want.
All right, shall we move on to the next paper, which is, it's all about size, Justin. Since we talked about the size of people, shall we move on to another size-related paper? And actually, before we do this paper, I just want all the listeners to stop for a moment and hand on hands, get a pen, write down. You're walking into resus. You've got a patient that needs an urgent tube. Which blade are you going to ask for? Are you going to ask for a Mac blade 2, 3, 4, 5? What's your go-to Mac blade when you walk into a room? Nothing else known. What would be your preferred blade for an unknown situation? Write that down on a piece of paper. Right, now jump into this paper and we'll talk about the evidence that this one presents.
I would really love to get the different answers, because like New Zealand, Australia, you don't have the respiratory technologist, so you actually have to make that choice. I bet you most of my colleagues in Canada, the answer is just whatever happens to get slapped in your hand by the person who actually set out your kit for you. But the backdrop is, in some places, this is apparently a heated argument. It's never really been in places that I've worked in. Maybe it's because we have those RTs. But the idea is some people really feel strongly that using a Mac 4 for everybody with the added length is a good idea, because you'll reach the vallecula in 100% of patients rather than potentially coming a few millimeters short and then not getting that lift that you really need. Seating the blade is really important. And yeah, that is a reasonable argument. But if you use too long a blade, the flip side is having the handle further away from the teeth, further away from the mouth, really does make it harder to lift. You're losing that mechanical advantage. And even, the blades aren't that much bigger in the mouth, but having a slightly bigger blade can make tube delivery slightly more difficult as well. So those are the flip sides of this argument of, should I just use a Mac 4 on everybody, or should I take a few seconds and really try to measure out a blade that might be good, knowing that we're probably not perfect at estimating tube size. This paper is not a great paper, but it did get a ton of play everywhere on social media, because I think people feel strongly about this. And so the people who are in we should use the correct size blade, Mac 3, really publicized this paper, because in a database of almost 1,000 patients, they retrospectively looked at this prospective database, and Mac 3 was definitely associated with better outcomes. First pass success, 81% versus 71%. So, a number needed to tube of 10 is not bad. Core macular grades were better, although I think it tells you everything you need to know about the quality of the data. Is despite the fact that first pass success is 10% better, mortality is worse, 2% worse with the size 3 blade, which sort of tells you that the data is just garbage, because you're not first pass successing more often and killing patients at the same time. That doesn't make any sense. And I think there's just no way you're eliminating the confounders in this, especially when it's a retrospective look at a database not collected for this. Why do you grab the smaller blade? Well, because the patient's nice and small and they're going to be easy to intubate. So is it surprising that first pass success is higher in small patients? I mean, that doesn't surprise me at all. I think that one confounder right there is that you're going to grab a smaller blade in smaller, easier to intubate patients is basically explains the entire data. And so I think this paper is sort of useless, despite being trumpeted everywhere as like the be all and end all of decision. That being said, I think it makes sense to grab the blade size that is going to be the best for the patient. I've never really understood the flip side of that argument. So yes, I use a size Mac 3 when I think the patient is smaller, and a Mac 4 when I think the patient is bigger, which I guess is what this paper is telling us to do. But I don't think this paper actually tells us anything.
Fair enough. Now, I will say my bias prior to reading this paper was that I've been teaching for a long time that if you had the choice and you're in the middle, you should pick a Mac 3 blade. So I love the fact that this reconfirms all of my biases, and I'm obviously correct.
That's how to do evidence-based medicine. Take your biases and find the papers to support you throughout the rest. The confirmation bias is great.
But and I guess from a mechanical point of view, like one of the projects I'm sort of working on at the moment, and hopefully we'll be able to publish something on the intranet at some point, is about airway videos and watching techniques and seeing what people get right and what people get wrong. And I think that seating of the tip of the blade in that vallecula right down at the hyoepiglottic ligament is so important. And the problem is that everyone thinks if you've got a longer blade, sure, you'll get there more, but then the first move that you do once you're in that great seating position is not the move that you want to do. Just by having a longer blade, you're going to rotate that blade back towards yourself as you lift it. Whereas if you've got it seated really nicely where it's just the right size so that the handle's in the right position, you're lifting away from yourself, then you'll get that nice lifting maneuver where you'll flip the ligament and pull the epiglottis out of the way. So I do think that it's more elegant to use the correct size blade, and I think that most people can get away with a 3. Although I think there's a good number of people that you do need to get a 4-4. And when they looked at the raw data in this, like obviously men, the more got a 4 used, and the taller you were, basically, the more people used a size 4 blade. So if I'm intubating a 6'4", bloke, sure, I'll reach for the 4. But I think the most important thing isn't the blade size, but it's about knowing that when you're in that right position, that you've got the correct depth and the handle's in the position you want. And if you don't like it and if you're struggling, then you throw that blade away and ask for the other one. That's the guts of this, is don't get sort of stuck down that sort of tunnel vision of, yes, I must keep trying with this blade. So if you're really struggling, go for the next blade, which is the easy thing to do. The only thing that I would say that was fitted better than the blades in this is the data, because Justin, you're the bright statistician here, but they did a thing called, what was it called? Inverse propensity weighting of the data. So basically they took all this raw data, which was taken from some studies in an ICU population, and then they sort of, if you looked at the raw data, it all sort of made sense. And then when they did this IPW weighting score and changed everything around it, basically everything looked basically the same except for the point that they were trying to make. And I'm not sure how that works in stats. I'm not as clever as you, but it seemed like there was a lot of data fitting which made the blades fit.
Yeah, it's why I give an evidence-based medicine lecture every year, and I tell basically all the students and residents, just ignore stats and just think about things in the most common sense way. If the things don't work out, if it's not a fair race, the stats are completely irrelevant, and it's only probably 1% of trials where you really have to dig into stats to understand it, because you can just look at it on face value and be like, this doesn't make sense. So who the hell cares about what stats they're running? It would be my general argument. It needs to be a fair comparison, and this is just clearly not a fair comparison. It's really hard to demonstrate in live models, because obviously we don't take our time when we're intubating patients. But this is one of my favorite things to show residents in simulation. And, plastic is not quite the same as a live model. But, we get so focused on the amount of force and lifting heads. And there are patients where you got to lift a little bit, and you got to lift their head, and you got to do some external laryngeal manipulation. But honestly, if you just take your time when you're not stressed and have this like plastic model in front of you and just hold the laryngoscope in a couple fingers, it's amazing how much 1 millimeter makes a difference. I have them stand there for 10 minutes and move the laryngoscope blade 1 millimeter forward, 1 millimeter back. And if you find that fold 1 millimeter forward, all of a sudden, boop, the epiglottis flops up and you have an amazing view. But 1 millimeter too far and it's not working, 1 millimeter back and it's not working. And so it really is all about very, very gently advancing that blade to the right spot, taking your time. I love this. Has changed so much since I trained. At least, slow is smooth in intubation. Find the midline, find the epiglottis, find the uvula first, find the midline, and just slowly get yourself into place. And yeah, occasionally you still do need to use a little bit of force after you get there, but honestly, most of the time you don't. Although I guess, leading right into our next paper, most of this entire conversation has been lost as we move from direct, where this is super important, to video, where, I don't know, whatever, just shove it in and it mostly works anyway.
I don't know. So yeah,
I'm being facetious.
No, we should clarify that paper that we just discussed, where we were talking about size 3 versus size 4, that was purely for direct video. That was not video laryngoscopy. So that was direct, so old school Mac blades. And I think that your technique is much more important when you're using the old school Mac blades, because video is very forgiving, and having someone standing next to you telling what you to do is a thing when you've got video, which doesn't happen with direct, so you can struggle. So shall we move on to the next paper and put this baby to bed, get rid of the airway segment altogether?
Yeah, I mean, I don't think we necessarily need science on this. I think we talked about that when we did the device trial, but this is another one. This is by Rutzler in JAMA, just published 2024, video laryngoscope. We'll just say VL versus DL because I can't talk right now. Endotracheal intubation in the operating room. So this is an OR study. It's a cluster RCT, and just like the device trial, video is significantly better for first pass success. I was going to ignore this trial. It definitely didn't warrant its own write-up. The big thing with this trial is, I don't know what happens in America, but an anesthesiologist only intubated 2.7% of the time. I don't know what they're doing or what they're getting paid for. Like they're just doing Sudokus in the past. So there's a bunch of nursed anesthesiology here, but a bunch of trainees. But when 97% of your intubations are not being done by an anesthesiologist, it is really quite interesting. But more importantly, just like we go back to the BASS paper, to me, you have to ask yourself whether it's a fair fight and whether you're looking at the outcome you really care about. And yeah, people talk about first pass success all the time, but first pass success is a surrogate outcome. What you care about are clinical outcomes like hypoxia, which they don't tell us anything about. And I know that there's a bias in these trials. With video, you get a really good view. And with a really good view for quote, quote, first pass success, you might take an extra 10 or 15 seconds trying to pass the cord because it's right there. Whereas with direct, when something's not right, you know it's not right because you're not getting good view. So you come back out and maybe you change your blade or maybe you do something else. So I think in the end, you probably got intubated in around the same amount of time with the same degree of hypoxia and everything else. Now, this paper doesn't tell us, but there's a built-in bias where first pass success is going to be higher with video just because of the view. You're going to take a little bit longer and try to pass that cord, whereas you don't get that with direct. So I don't buy this data at all. I don't buy that there's really a clinically relevant outcome. The much better trial device showed that there was better first pass success, but there was no clinical difference. But I also don't buy that we need all that much science. Video is clearly better, not necessarily because of the view, but because of exactly what you said. If I'm training, if I'm watching a student, I need video because otherwise I cannot help them get better at laryngoscopy. It's impossible. And even when I'm doing it myself, it is so nice for me, we have our RTs, respiratory therapists, but even just for the other doc in the room to be able to see. And even if it's not like giving me that little bit of laryngeal support, just knowing that, maybe they should go over the thing and get the LMA and get that scalpel out. The room is much better prepared when you're using video. I think the reason the evidence is important is should a hospital with 36 operating rooms running buy 36 video scopes? That is a reasonable argument. At this point, though, in an emergency departments should probably have a video scope, and I don't think we need much science to do that. And that's one. And then I don't care what you do from there. Is sort of my point.
I guess the other thing, if people aren't going to read this paper, the other thing to know is that the video device that they used in this was not the CMAC, which is in Australia. I don't know about Canada, but CMAC is basically the universal thing. This was done with a GlideScope, which is a hyperangulated blade and usually requires some sort of stylet introducer to get the tube around the corner. So it's a very different sport to what the standard geometry CMAC blade is, that I'd say is 90% of the market in most places in Australia. Don't know about Canada.
Yeah, I think the argument. So I think most places still have hyperangulated. I just fought pretty hard in one of my two hospitals to get normal. So we still use a GlideScope, but we have normal geometry blades with a GlideScope now. But the other hospital I work at, the only video is hyperangulated. So I think that is still where this question was up in the air. Is that if you are comparing two dramatically different products, maybe there's a question there. But if you have the exact same standard geometry blade and one has a beautiful video screen that everybody else can help with, and one does not, I don't think there's much of a question. You don't need that much science for this. So I don't care. I will happily use a standard geometry video for every intubation that I do for the rest of my career and not look back and having that backup of hyperangulated. Most of the time I still try to intubate direct using that video blade just to keep my skills up, but it lets me glance over to the screen if I need to, and I usually don't. So maybe that's the argument. Maybe I could just use direct. Maybe I'm wasting a little bit of money, but for the, and that's another thing in the OR with doing these multiple times a day. These are often disposable blades. Maybe there is some financial cost, but in the operating or in the emergency department, where honestly I don't get to intubate that often, a couple times a year, cost is not an issue. This is a critically ill patient. I'm going to use the best possible technology I can. It's a pretty easy win for me. Look, there's no black and white in all of medicine, so people listening are going to have to know their own local environment. But I think every emergency department probably needs to have a video option, and I'm going to use video for the rest of my career, even though I did pride myself. I thought I was pretty good at direct. I spent a lot of time mastering my skills, but man, video games are fun. I'm going to do that for the rest of my career.
All right, so we're going to end the airway segment there. I think. Can we never talk about VL versus DL again? Can we just finish like that's it? We're done. Yep.
Yeah, I mean that seems like a reasonable spot to be. Although they're easy papers to throw in, people like to listen to that. So I don't know. Sometimes I might get sucked back in. I can't promise you.
Although we're moving on to the much more exciting dermatology segment of the podcast. Oh, so I just realised that with our initial little rash discussion and these two papers, we're actually doing 3 dermatology segments in one emergency medicine podcast. I think we're cutting edge.
And yeah. We didn't think to invite your partner on to help us out because neither of us know anything about dermatology. But
that's right. My wife is very, very good at skin stuff. She's a very superficial doctor. That's all I'll say.
But I don't think. Do you guys even have poison ivy in Australia? So am I just eliminating most of our audience by including this paper?
No, poison ivy is not native to Australia. It is an introduced species in like some gardens and places like that. So usually when I think poison ivy, I go back to that very creepy Drew Barrymore movie from the early 90s. Am I dating myself here, where she tries to seduce some middle-aged bloke and pushes him? I think she falls off a balcony in the end or something. I can't remember the exact plot, but it was quite disturbing because I'd sort of grown up with Drew Barrymore as the kid from E.T., and next thing you know, she's tongue-kissing some middle-aged bloke. So it was a formative moment for me in my teenage life.
Always high points on the BroomeDocs podcast. really clinically relevant stuff. We can probably do this one really quickly. I actually couldn't find even a PDF of this thing, so I have it in a Word document that tells you the quality of the papers that we're covering.
23 years old, so yeah.
back from 2000, bringing you the best and newest evidence-based medicine by why do I keep offering to do the names? Stibich is the name. That's good. That's as good as I can do. Cost-effective post-exposure prevention of poison ivy dermatitis. Honestly, I didn't know that you could prevent poison ivy, and living in a place where there is a lot of poison ivy, especially with my favorite pastime being golf. Like, our golf courses are just covered in them. I feel like I should have known this, but I had no idea that you could prevent it. It makes sense because it is an oil that gets on your skin, and so the whole idea is get the oil off with some kind of surfactant. But I honestly had no idea. And so this is just a tiny little.
More about your golf, Justin. If you're getting into the poison ivy, you should stay in the bit where they cut the grass in the middle. Yeah.
Yeah, but that makes golf so boring. What you want to do is go off into nature. Like, people do hikes for a reason. So I want to be off in the forest. That's where the fun stuff is. You're not going to see a deer in the middle of the fairway. That's ridiculous. Get into the forest.
Carry on.
Anyway. This is a classic. I don't think you could get this done 23 years later because they used medical student, quote unquote, volunteers, crushed up a bunch of poison ivy and just smeared it on their arms. So that sounds like a great medical student volunteer paper. And then they tried 3 different things. There's apparently a commercially available product that is to prevent poison ivy. Then they used some automotive grease and dial dish soap. And then poor medical student volunteers, they left one area completely untreated. They only put the treatments on 2 hours later, which I found a little bit weird, but I guess maybe that is real life. It takes you a couple hours to get back to your cottage after being exposed. I don't know, but I feel like the outcomes would probably be better if you didn't wait 2 hours to apply the medical treatment. They checked their arms at days 4 and 7, and lo and behold, all of these surfactants seem to decrease your rash by about 50%, but there was no difference between them. So my takeaway is you don't need to buy any commercially available products, but some dial dish soap in your golf bag if you are a golfer or just have around seems like a reasonably good idea in a relatively low quality overall paper. But a nice little trial. I like it. It's an interesting kind of trial aside from the forcing medical students to have a poison ivy rash for a week.
I know exactly what I'm getting you for Christmas now, Justin. A bottle of dial dish soap that'll fit in your golf bag. It keeps on giving. I would like to pause for a moment and cover the topic of medical student volunteers, because a phenomenon I've encountered recently is that we often use medical student volunteers for all sorts of things, particularly for ultrasound training. We often use medical student volunteers as like models to come along, and they learn from the teaching and they get to model, and they're usually young and healthy and have nice looking organs. That's all very fun. But recently there's been this trend towards we have to pay medical students to be volunteers, but they're not really volunteers anymore. And if we're getting them to do stuff like this, I actually feel like it's ethically worse to pay someone to put themselves in a position where they're potentially getting harmed, for example, getting exposed to poison ivy, rather than have them just do it for the love of science and volunteer, because you're not really volunteering if there's a big cash carrot at the end of it. I don't know. Seems a bit wrong, but your thoughts?
My guess is there was probably always a big cash carrot because they weren't volunteering for the love of science here. They were volunteering for a reference letter to a career that's going to pay them hundreds of thousands of dollars. But that's a underplay of the money. So I think the carrot and stick was already there pretty strongly, and it might be more problematic with the overlays of power and wielding. I don't know. I think a trial where you're doing significant, like, I don't know, I've had poison ivy. It is not comfortable. I would not volunteer to have it on me for a week. So just having it in the context of medical school volunteers seems problematic to me. I don't like, it's a good trial, and you need to get this kind of stuff done. So I'm not sure how I do it, but yeah, I want people volunteering for the love of science. And so maybe going to cottage country where people are dealing with this all the time and getting actual volunteers because they want to have an answer is a lot better than just getting some medical students. And I bet you people would volunteer for this if you went around in the summer seasons to places where poison ivy is rife to be like, hey, we have some things that might help you in future years. Let's test it out. But it will make it harder on researchers, but I'm not sure that research always needs to be easy. Research needs to be good.
Cool. And my other question that I have for you, as we mentioned earlier, my wife is a skin person. Pretty much whenever one of my children gets any sort of itchy rash, she just slaps some ridiculously potent steroid cream on it. Does that work for poison ivy? Is that something that you do in Canada?
Yeah, it's just a classic type 4 hypersensitivity reaction, which I obviously know everything about, and so responds pretty well to steroids. Although it seems to be a different breed back in Toronto, and I guess I'm in a big city, so less environment. But where I did my training in Kingston, it was not uncommon for me to have to use like oral steroids, prednisone for patients. Like it was these rashes got pretty severe and pretty bad, and people are very different. I believe, although I never actually saw it with my own eyes because it was when he was a kid, but I believe my dad was anaphylactic to poison ivy. I don't know that the surfactant dial would actually have helped with that at all, but you can get some pretty severe reactions that don't respond all that well by the time, because unfortunately by the time you get to it, it's been a couple days because it is delayed as type 4 hypersensitivity. And the worst part is, and the reason that this is maybe really valuable is it's, the poison ivy only touches you in one spot, but it is a like oil that is really sticky and stays on your skin. So then if you touch it with your hand, now it's on your hand, you get poison ivy on your hand, and then you end up touching another part of your body, and it spreads pretty easily despite being just a contact dermatitis.
There you go. Okay, good to know. So I'll stay out of the bushes when I come to Canada, or I'll practice my golf before I go anyway.
There are a number of reasons. I've heard that we're starting to get mountain lions back on the East Coast as well. So there's lots of reasons to stay out of the bushes when you come and visit us in Canada.
All right. We'll move right along then to the next dermatology paper for this podcast. Our listeners are all going, what on earth is going on over there? This
all picture-based too, yeah. Audio podcast, nothing but picture-based thing. And there's actually no science in this at all. So I'm not sure why it's included, but I like this. I don't know what you think.
Well, I live in, this could be the funkiest new tattoo for 2024, I reckon. This is definitely one. So this is the Burrow ink test for scabies, which was basically a one-paragraph case report from the New England Journal of Medicine in August 2023. So it's taken that long before someone's actually published this. This really strikes me as something that we could have done with like ink and blotter paper in 1842 or something if we really wanted to. But so the idea is that Sarcoptes scabii, the human version, when it gets into your skin, it burrows into the dermis or the superficial epidermis and burrows along and leaves these little track marks under your skin, usually in places like your finger creases, your wrists, your groin, genitals, that sort of area. Though in babies, often on the sole of their feet, if you're interested to know that as well. And these can be really hard. People just come in and they're itchy and you can't really work out what's going on. And so sometimes I do know people that get out the magnifying loupes and try and examine the rash to see these burrows to prove that it's scabies. These people in New England somewhere, I'm not sure where they were, they basically, what they did is they just took a little blot of paper with some ink on it and put it over the itch area and then waited a few minutes and then wiped it off with some alcohol wipe, so you're left with a bit of ink, but where the burrow was, the ink went down into the burrow and left a little sort of surface squiggly line so you could see the track of the burrow under the surface of the skin, and then they could say you've got scabies, and then they treat them with pyrethrin. I think this was just one patient report, but hey, if it works for one, it will work for many. I work in a part of the world where scabies is basically universal. It's part of life, unfortunately, for a lot of my patients, and it's really hard to get rid of because once one person in the household gets it, it quickly spreads to the whole household. Usually the way I identify scabies is that they are covered in pussy wounds. So pyoderma is what we tend to see. We don't tend to see these nice, neat little burrows. We tend to see pus, so superficial impetigo, essentially, which is what scabie looks like in my part of the world. And this is a big deal because this is how kids get rheumatic fever in Australia and other developing parts of the world. the old tonsillitis thing is a bit of a, I'm sure it happens, but I think it's a bit of a myth really in our part of the world. It's this bug that causes rheumatic fever. So good to know, but by the time I get to them, I'm sure that the ink would just disappear into the pus well, and I would never see the tract. But hey, if you're dealing with white folk, maybe this will work.
Yeah, that's really interesting. Is that just because they're presenting late, also being in the hot, humid tropics? So, like, basically, you're getting secondary infection from scratching and stuff like that.
Yeah, absolutely. So we have malevolent levels of strep and MRSA on everyone's skin up here, and it's hot and warm and sticky. And people don't tend to bathe a lot. It's not like an everyday soap in the shower sort of culture. So we do see a lot of this. So but I can honestly say I've never seen scabies present with the classic scabies rash of the burrow. We just see it as pus, unless it's someone who's living a good, healthy, clean life. That doesn't tend to happen. And probably the best predictor of who's got scabies is you ask them how many people live in your house, and if it's double figures or more, then you can be guaranteed it's going to be scabies. Yep.
Yeah, so we see a fair amount of this, and in the cold, dry climate, basically the skin looks like dry, itchy skin, and often there's excoriations over top of it. So I find this very, very difficult. I think this is a really interesting, like the pictures speaks 1,000 words. People should look. I can't wait for the day that this actually works. I've tried it 3 times since reading this paper, and so far I haven't been able to find a burrow. So I think that there's a clinical lesson there. So in Canada, for the most part, I think we're treating empirically. If you have a decent story coming from an environment where it could be scabies and you're just itchy all over, I'm going to probably treat empirically. And not seeing this on this ink test, I probably shouldn't be talking me out of treating if I was thinking about treating anyway. So mostly I'm doing this for one day to be able to run over to my students and residents around the department and be like, look, I'm a genius. I found scabies. But I mean, currently my skin exam for this, aside from just randomly guessing because of the amount of itch and because I can't see anything else, is pretty poor. So having an extra tool for me being a very poor dermatologist, I thought was interesting. But yeah, we have no idea what the likelihood ratios are here, what like the actual sensitivity and specificity of this test is. But it was a neat little paper that we've probably spent way too long talking about. If people want to look, we'll have the pictures in the show notes.
I just thought of a great use for this, Justin, just while you were chatting there. So this could be the cure for delusional parasitophobia. So if someone comes in, so I've got bugs under my skin, and you put the ink on and you show that there are bugs, they're no longer delusional. So perfect.
Just completely cover them head to toe.
Dip them in ink like a Smurf.
God. Yeah, I was trying to think of other uses. Like, when do I care whether the skin has been broken? Could we use this for needle stick injuries to see whether you actually broke through the dermis or not? Does it absorb? I feel like I need better accuracy in this situation.
I reckon this should be part of the medical screening for all psych admits now.
Yeah, it's good. Yeah. I like it.
Don't worry about the MRI.
It identifies it. It would help whatever you call them in your hospital, the code yellows, the missing psych patient, because every patient in your hospital is just going to be dyed purple head to toe. It's fantastic. It's not stigmatizing at all.
Now, hang on, back up. You have a code for missing psych patient in your hospital?
It's just all missing patients, but yeah, a code yellow means a patient has gone missing. Yeah.
Oh, right. In Australia, a code yellow means that the ED is ridiculously overflowing and someone needs to come and do something about it. So, yeah, it happens every day.
Yeah, they've given up on that. Yeah, I think literally at 8 a.m. I can't remember what's our call it, a gridlock phase, and we have various levels of gridlock, which is a really bad thing. And basically, at every morning, they just say gridlock phase 4 again for the last 22 years. So I don't think it actually does anything.
Awesome. All right, let's move on. We're going to talk about a really fascinating topic, which I guess I didn't really know about. Not like you, I was listening to the podcast with our good mate Scott Weingart, and this is an international thing, which it strikes me in retrospect that probably we should have worked out maybe 20 or 30 years ago when we started doing this research. But hey, we're learning about it now. So this is the position paper on reporting of norepinephrine formulations in critical care from the Society of Critical Care Medicine and the European Society of Intensive Care Medicine Joint Task Force. This was in Critical Care Med just this month, actually, hot off the press. So essentially what they're saying here is that not all noradrenaline, I'm going to use the word noradrenaline, you use norepinephrine, and we'll see where we end up in the middle, okay?
Yeah. Sounds good. Yeah.
Can I ask you, does norepinephrine weigh the same as noradrenaline?
It's very, very confusing. I have no idea. I have a picture of norepinephrine on my screen. That's all I can go by. I know nothing else. No, this paper confuses the hell out of me.
So basically, there's 3 different formulations in the world of noradrenaline or norepinephrine, and there's the norepinephrine hydrochloride, where you've basically just got norepinephrine molecule with a bit of chlorine stuck to it. There's norepinephrine bitartate, and then there's norepinephrine tartate. So there are 3 different formulations, and basically they're the same base molecule of norepinephrine, but what the salt of that molecule is different depending on which formulation you happen to have in your hospital or your country or your continent. And it seems that varies around the world. Does that really matter? Because we all chuck up the NORAD and we start titrating it up or down to see what happens to the patient's blood pressure, and everyone goes home and we're happy. It doesn't really matter what the formulation is. It's the blood pressure or the response to it that really counts. But there are a few situations, and particularly in the research world, where this becomes a cropper. And unfortunately, norepinephrine tartate, which is what we have in Australia and which I have in my hospital, is about each molecule of that weighs about twice as much, pretty much, as norepinephrine hydrochloride. So if you're comparing a mics per minute per kilo rate, you're actually getting different amounts depending on what you're doing. And that doesn't really matter if you use the same for your whole career, but when you're comparing across hospitals or across research papers, then that becomes an issue. So, Justin, are you running out and restocking all your noradrenaline, or how are you dealing with this realization?
Yeah, for the most part, I don't think it matters clinically, but I think it's important for us to know. And this is not just going to be noradrenaline. There's a lot of medications. We dose everything by weight, but when you have to basically to make things, some medicines dissolve in liquid, you have to combine them with acids. And when you're weighing them with a combination of stuff that you don't actually care about, the weight all of a sudden becomes a little bit less relevant. What we care about is the amount of noradrenaline getting into your body, not the total amount of whatever salts that you're putting into your body. So as you say, for the patient in front of me, I'm literally just titrating up and down. So it doesn't matter that much, but it could throw me off if you move to a different hospital and you're used to patients getting better on 10 mics a minute of norepi, and this patient's requiring 20, it might seem that like they're sicker and like you need to be doing something else, whereas that's the exact same dose. I don't think that's as big an issue. There are 2. I've never worked in a hospital. It sounds like I think America has a lot more strict nursing limits, but if there's a hard cap where you cannot go above X amount of noradrenaline, you better know how much you are or what kind your hospital is using, because if you had a hard cap and you're using the tartrate, which has less actual norepi, you could be using, like some hospitals have a hard cap of 30 mics a minute. That's only 15 mics. I have lots and lots and lots of patients that are over that in day-to-day practice. And then the other thing is a bunch, I don't use scores for almost anything, but a bunch of scores. And when you're comparing patients to research, a bunch of them have if you get above this amount, the patient is sicker and that goes. So comparing to research probably matters a little bit. Now, it sounds like Canada's been way ahead of this. So I include a picture in the show notes of a picture I took of our norepinephrine about 10 years ago now, and it says 1 milligram base per 4 mLs. So apparently in Canada, we've always been measuring by the base amount of norepi in there and not by the salt amount. And so that's what this paper is recommending, is that we should all just be saying how much actual norepi there is in there, sort of like how we use standardized units of many other medications rather than weighing it total. So this may not matter at all to some people. It probably doesn't matter much to most people. We probably rambled on a lot about a very esoteric and nerdy topic. But when something like this comes up where you just had no idea that you might be using twice as much or half as much norepinephrine, that's sort of surprising to me. I thought it was worth sharing and chatting about.
Cool. Yeah, I don't think we need to say any more. Go and look at what your ampule has in it. Have a chat to your pharmacist and make sure that you know what you're giving. And obviously, it doesn't really matter that much, but it's useful when communicating with people around the world or across countries. So cool. All right, let's move on to the controversial paper of the month, I guess we could say. I don't know if it's controversial anymore. It's 2.
I think we're going to get more controversial with the next one. So I think we will finish on 2 controversial papers. Cool. But people have some strong opinions about Paxlovid, or I guess we're supposed to not say the brand name, but I can't say all the viral names. So Paxlovid.
No, I'll have a crack at it. Nurmamaturavir. Yeah, go for it.
Yeah, it's got something else in there, right? And I only have the Nirmativir written down in front of me for some reason, because that's all they put in their title. Like, I think the only people it's going to be really controversial with, I don't know what the laws are in Australia, but if Pfizer's going to come after me for saying that they probably should not have hidden important clinical data for 2 years, as drug companies making billions of dollars are apt to do. But this is the EPIC SR paper that when they published EPIC HR and people started using Paxlovid, we knew at the exact same time that this trial was negative. But for some reason, the quote unquote positive trial came out with great fanfare, and this has just been sitting in somebody's desk drawer for a couple of years. Lo and behold, it's the negative one. And Pfizer has made tens and tens and tens of billions of dollars while we were waiting for the negative trial. Now, good science. We talked about EPIC HR when it came out, and it was not a very impressive drug. And I didn't think people should be using Paxlovid all the way along. And now we have data that shows us that we were probably right about that. This trial, like there's going to be controversy about it. Either way, it is on paper exactly the kind of trial that you want, aside from the fact that it's entirely run and designed by the drug company, and so with huge conflict of interest. But in terms of the catchphrases, it is it's a placebo controlled, double blind, everything that you want about it. And the group of patients is much closer to what we're dealing with now, in that it is mostly vaccinated patients. But vaccinated high risk. So, the patients who still have comorbidities, or you would take unvaccinated patients with no comorbidities, which was what would make them lower risk. They changed that population around partway through the trial because, they say it was to quote unquote balance out the trial, but they don't actually explain that at all. Mostly it was because they were selling Paxlovid already, and they didn't want to undercut their sales. I think
cynical.
Won't get myself into too much trial, but they don't explain. I think the quoted word was, "We wanted to balance out the trial," but I don't know what that means. But essentially, there was no benefit here. This trial, because it was standard risk patients, was looking at like symptom alleviation, and there was no difference in symptom alleviation. There was also no difference in their key secondary outcome, which is hospitalization or death. Now, we've brought this up before. They looked at quote unquote COVID-related hospitalizations, which means like if you got admitted for a side effect from Paxlovid, that wouldn't count in this outcome. So it's an inherently biased outcome. And people will look at that. The COVID-related hospitalization was half if you look relative risk, but it's 0.8% versus 1.6%. So like no RCT is going to definitively prove things one way or another. My take is the only data ever that has been positive for Paxlovid was industry funded entirely, highly conflicted. And it really has not been that impressive all the way along. So I don't think anybody should be using Paxlovid until we have independent, high quality research. There are going to be some patients where you're going to be sitting on the edge and debate. So in a patient who's like severely immunosuppressed, patients undergoing chemotherapy, things like that, I think the guidelines will still say to use it. I don't know that we have any data to support that really, but I think that's reasonable. If you have significant immunosuppression, I'm fine just testing for COVID and using Paxlovid. For everybody else, this has been out, although it's been out for me because we knew this data was negative for 2 years. I think this was very similar to Tamiflu, one of the most overhyped medications of our generation, and they knew they can get away with it because the governments needed to seem like they were doing something, and so we got billions and billions of dollars, taxpayer dollars, siphoned off to big pharma again. I love it.
Have we learned nothing in the last 20 years? Probably not. I guess completely agree with everything you said there. It's a negative trial. It should be positive based on all the biases that are within the trial, but it still remained negative. So, and I wasn't prescribing Paxlovid before this, and I'm certainly not going to be doing it afterwards. There's a couple of things that I would say about this trial. Number one is that one of the reasons that young, otherwise healthy or vaccinated, low comorbid people with COVID come to the emergency department, I think, is because they think that they need some sort of special medicine to treat them. And that means that we're putting all these people with COVID in the same waiting room as our oncology patients and our old geriatric patients, who are the ones that are actually at high risk from getting bad symptoms from COVID. And I think that's an unrecognized phenomenon, that the fact that these people come to the emergency department and are in the same airspace as our vulnerable patients is a problem. And so I think we need to get that message out there that, if you want this medicine, go to your primary care doctor or something, but don't come to the emergency department if you're low risk and otherwise well, because that's potential real harm of people seeking care for what's been a really well marketed drug, essentially. So there's not many antibiotics that have been developed in the last 30 years that the public know the name of and can tell you all about and have a strong opinion one way or the other. Like, I don't have people debating with me whether they need Tazapip or meropenem for their, like, it's just crazy that people know about all this sort of stuff. So good that the public are aware, but I think we need to make them aware of this sort of stuff so that they don't come to the ED and wait for 3 hours for it's an unnecessary medication.
Yeah. I think, unfortunately, that was so underplayed. Like, I've been saying that from the beginning, because yes, you can isolate Paxlovid. Look, there can still be some debate because Epic HR was positive, although I'm very much not convinced, and this is negative. But any analysis that just looked at this on a one-by-one patient level was just such a flawed analysis, and I could not get our local COVID science team to look at it from that perspective. But if you say that patients need Paxlovid, and it has to be given within 3 days, what you're saying is that every patient in your entire area who has sniffles must rush to the emergency, because you can't get into primary care within 3 days of your symptoms. There's the weekends and everything like that. So what you're saying is everybody who has any kind of respiratory symptoms, and Paxlovid or a COVID has all sorts of symptoms. So basically anybody who has any kind of symptoms must go to an emergency department and get tested for COVID. Can your system handle every patient getting sick, going to the emergency department just to get tested? So, and at the time, the first wave, COVID was the primary thing. But as like flu comes back around and everything, basically what you're saying is you need to test everybody. I would want to know the number needed to test to find that one COVID patient to then have a drug that is very underwhelming in its evidence. It was very clear that this was going to fail in the first place. And I think there's been real harm from the early recommendations. In Ontario, there are lots of reasons that our emergency departments are overwhelmed, but it only takes 10 to 15 extra patients a day coming specifically looking for this and sitting in the waiting room for a couple hours and coughing on people to continue propagating this thing. Those recommendations were so flawed from the outset, and it makes me relatively angry that they came out like that. And look, it's not Pfizer's fault. We should expect greedy drug companies to try to maximize their profit. That's their only role in life, is not to help patients. Their role is to make as much goddamn money as they possibly can. This was clinicians' fault. Anybody who could prescribe Paxlovid off of less than ideal data from financially conflicted data, it's our fault. We do this over and over again. We did it with Tamiflu. We did it again. We need to introspect. And I understand. We feel pressured, right? We feel pressure when guidelines come out. So it's not the individual clinician at the bedside so much, although I do think we are doctors. We need to make good decisions, and we should be willing to stand up to bad guidelines. But it's also the guideline committees who came out and told us that we should be doing this. This is the medical community's failure, not Pfizer's failure, despite the fact that they sat on this data for 2 years just to make money. So everybody has a small thing, but we should expect drug companies to do this. And so it's up to us to be good at evidence-based medicine and not fall for their crappy tricks.
Yeah.
Right over.
Although a few positives about this paper is I did learn a new word. I'd never used this word, and I've been around for a while. But dysgeusia, that's a great word. I Googled what that meant, but it's dysgeusia. For those of you that are smarter than me, just ignore the next minute. But dysgeusia is the funny taste in your mouth, that metallic taste that you get from some medicines, and like I guess things like metronidazole do that to you. So that is a side effect of Paxlovid. So if nothing else, it will leave a funny taste in your mouth. And I guess the only other group, Justin, that I would be prescribing this to would be Pfizer shareholders, because they're the only beneficiaries of us prescribing this. So maybe that's the criteria we should use as a Pfizer shareholder. Sure, here's your dysgeusia medicine. Here you go. Cool. All right. Being facetious. Anything else you want to say about that? I
guess maybe there's one other evidence-based medicine point that is worth bringing up, and that's the harms. Because one of the big comments that you'll hear, and this comes up in all sorts of research, and it'll come up again next month, I think, is that, it's safe. There's not that many harms. Sure. But the way that the data is collected in these trials is so ridiculous to me that it's really hard to make sense of it. I can't try to get the numbers back in front of me. 25% of the 25% of the placebo group had an adverse event from quote unquote placebo. What? Like, placebo causes 0 adverse events. We can debate nocebo effect all you want. That's a complicated topic, but it's 0%. So when you're listing 25% harms in the placebo group, what you're really doing is biasing in favor of Paxlovid. Because if the rate of harm is say 2%, 25% versus 27% is lost in the noise, whereas 0% versus 2% is like very easy to see. And it's one of the ways we know that RCTs are not good at looking for harms, but it's one of the ways that really biases these trials. And now I understand, because when it's a brand new experimental chemical that we're shoving into people's bodies, you don't know what harms to look for. So basically they look for everything, but that includes looking for things that are caused by COVID itself. So yes, every patient is having symptoms after you give them these drugs. It's a mess. So I think the EBM lesson is you just can't trust these trials on harms. It's not the way that we look for harms, and always have a look. When you hear that a trial has no harms, look at the rate of harms in the placebo group, and that should give you a sense of how much you should trust the data.
Cool. Thank you, Justin. Good rant. And that was the one big number that jumped out at me. It was 25% harms in the placebo group, which makes you scared to get out of bed in the morning, to be honest. Like, what could happen? All right.
I mean, I don't know. After 40 and 28, getting out of bed does have 25% harms. That is just baseline, I'm sorry to say.
Stay in bed, people. That's the lesson there. Yes. Okay, we're up to our last paper. We're doing pretty good for time. Now, if you work in the NHS, this is a paper for you, I think, because if you follow the Twitter or the platform formerly known as Twitter, my feed from all my UK NHS buddies recently has been full of stuff about comparing doctors to PAs to other different mid-levels or whatever you want to call different healthcare providers around the world. And I'm not going to say too much. I'm just going to introduce this paper and then push the Justin Rant button, and off you can go. So this is What's in a Name, the Problematic Term Provider, and this is essentially an editorial written by Dr. Scarf and Federation something Practice 2021. So it's a couple of years old now, but very relevant to what's going on in the world at the moment, with quite a shift around the world between, particularly in the NHF, if you follow leads about what PAs represent in terms of threats to doctors, or what we're actually going to end up with in the end in terms of quality of care and who sets those benchmarks. So go for it, man. Give us the rant.
Yeah, I found this paper to be really fascinating, and I think the least important part is the part that you hit on, but I think it's the part that will make this really controversial. And so we can come back to that at the end. I've talked a few times. I mean, my master's thesis was on the impact of words that have on people. And I do think words really matter. And I think there's a lot of good research that just subtle changes in language make a huge difference. But I think most of us just go through life and put our heads down and don't pay attention to it. The problem is the people who do pay attention and really push language agendas have a lot to gain from it. And so I think there are some subtle changes that happen behind the scenes that aren't necessarily great. And often when people are really pushing language, they're doing it for a reason, whereas most of us aren't that careful about the words that we choose. Provider is really interesting. The first instance is sort of scary. And anytime you start talking about 1930s Germany, you start worrying about getting yourself into trouble. But apparently the first time that doctors were ever called providers was by the Nazis trying to discredit doctors who were trying to talk about the horrible things that were happening. So it's not a great historical term. And basically, you're trying to take away the power or the prestige that goes with the term doctor and just put on some generic term, which is an interesting effect. And I think that is used a lot in medicine. I think the most concerning to me has to do with, I've always refused to call patients clients. Yeah. That is a thing that drives me nuts. And I think provider is very much the same. His argument is it really came to the use of this term in the commercialized American healthcare setting, where the provider is, I am selling you a product. I am providing you with a product. This is a commercial interaction. Whereas the root of the word doctor, Latin doctor, is to teach or to instruct, and to move away from those that root terminology into a commercialized language of client or of provider, I think is very problematic, and it takes us away from what medicine is really about. And to me, that is the most important or most interesting part of his argument. He does bring up the other aspect, which is the confusion that happens to patients. Patients don't necessarily know who they're talking to in a healthcare setting, and we do use the word provider to cover a large range of different experts. And I think there is a role for a lot of experts. And I have seen the PA argument from the UK side, and I think it's a really complex topic and maybe not one that we want to delve too deeply in here. But I've worked with some fantastic NPs and some fantastic PAs. But when you're a patient and you don't know who you're talking to and you don't know who they are, I think it's important to know whether you're talking to a PA or an NP or a doctor. I think that's still, titles still sort of matter to some extent. And by just labeling everybody provider, this is done intentionally. This is done as part of a campaign to build or to bring prestige to some extent, or either lower doctors to the level of other providers or bring other providers up. And lowering and hiding is, I'm bringing some judgment in there already. But look, we have different levels of training, so it's not about. I'm not saying I am better than anybody else. PAs provide incredible level of training, but we shouldn't be glossing over the differences. And I think his other argument, and again, I think this is the less interesting and less important argument, is the confusion. And even him, I think he's fine with confusion, because he says, look, if we want to continue having a single label to use for everybody, that's fine, but don't use the commercialized provider. Use something like healthcare professional. And I think that's important. I have no problem having a same label as a PA. What I have a problem with is the commercialization of language, and that's what caught my eye with this paper. Is that I do think it's very similar to calling patients clients. Patients are not here; they don't just get to demand the MRI, which a client would. If I'm a provider, they can buy that MRI. There are a lot of docs who work in that model, which is the CEO healthcare, where you just come in and you buy the entire thing. There's a lot of people selling you whole body MRIs every year to screen for everybody thing. That's not the kind of that's not healthcare. That's not where I want. That's not where I want to be. That is a provider client relationship. So that's the longer rant for me. There's three. He had three major issues, but it's the middle one to me: the commercialization of healthcare that really struck home. And I think just a waking up. I think language does really, really matter. And for most of us, look, we're trying to see patients. We don't pay that much attention. But as you see a new language, like it struck right around the time I was in medical school. Well, all of a sudden, patients weren't patients anymore. They were clients. I think it's worth just sitting back and being like, why is that happening? And normally there is an agenda behind those kind of language changes, and it's worth paying attention.
Perfect. Yep. I think, it's worth a read, and the history of it's quite fascinating. I certainly learned a lot by reading through that history and understanding how that came about. I think obviously it's going to be controversial, and the hoo-ha that's going on in the NHS at the moment. I think at the end of the day, as a team of healthcare professionals, doctors, nurses, NPs, PAs, whatever, working all together. We have physios, OTs that work on the floor with us, pharmacists that work alongside of us as well. We're all there to provide the care, and we all have our separate jobs to do. And it does my head in when people start bickering over, higher, lower, what's my title, all that sort of stuff, because we all have our individual jobs to do, and we all have our particular skill set. And like, I can't do what the pharmacist does, and I can't do what our NP does, and they're fantastic at what they do. And so I think we just need to appreciate everyone's roles in that. And there's going to be a big power struggle going on over the next couple of years by the sounds of it. But at the end of the day, the only way that we can really mess this up is by forgetting about that word care in that whole package, and that we're healthcare providers and we're caring for patients. And if we start, like you say, commercializing it, or if it starts getting in the way of that care, then that's when it becomes a problem. So if there's a metric that you're going to follow, I think that's what you need to look at: is are the patients or the people that are coming to seek care getting what they need, and are we actually shooting ourselves in the foot by having all these discussions? And completely agree. None of us really have much interest in becoming providers of commercialized care. It seems like a very bad model. And if you don't believe me, just look at the spending in the US healthcare budget compared to their medical outcomes, and it seems like it's not going that well. So I'd much prefer to work in a system where there's no money involved, and we're doing it for the benefit of the people in front of us, rather than titles or ranks or dollars. Yeah, I think we're done.
I think that was a really interesting paper to me. And look, I'd be interested in if people really have strong arguments against us, and negative comments are still good on social media. But what I'm more interested in, like, I actually don't know that much about this, and I love learning new things. So I found this paper interesting, but I don't know this history. I don't know that much about linguistics. So if anybody in our audience either has other examples of words or knows more about this history, I am very happy to be educated in the comments. I would prefer not to get into the argument about like who is what level of provider and up and down. And even the language I use probably is problematic. I'm not good at language. I'm interested in it, but I can admit that I might have used the wrong words as we're talking here. So look, if you want to leave negative comments, go for it. But if you have educational comments for me, I would love to learn more about this kind of stuff. So happy to hear more about it anywhere.
You know who we need to cover this? We need Michelle Johnson to come on and talk us through the history of the language, because she loves a good dystopian sort of conspiracy theory. So I think, Michelle, if you're out there, jump on in, tell us what we're saying wrong, because we're just a couple of dumb guys on the internet at the end of the day. So we'd love to hear your wisdom on this as well. Cool. All right, mate. Anything else we need to talk about tonight? We're going to upset any other peeps?
No, I love that we decided collectively that we were going to try to do shorter and more frequent podcasts, and we're still at 1 hour and 20 minutes rambling on. So we'll see. We're going to try to do it every month for a little while. I bet you the next one, I have some conferences coming up, is not going to be a full 9 or 10 paper thing. So probably will be closer to 4 or 5 next month, and maybe a slightly shorter podcast. But don't worry, we'll end up rambling and talking about bullshit no matter what.
I love that you think that it's the number of papers that's going to shorten the. we can ramble for hours about anything. We don't need papers. The papers are just a framework.
Yeah, I think we talked for 15 minutes about Scabies ink test and another 10 minutes about the dosing of noradrenaline. Like, I think we got some problems. 100%. I think I just get excited to see you, my good friend, but you're on the other side of the world. So we got to stretch these out for a long time, and hopefully the audience in that third chair out there at least semi enjoys coming along with our nerdy medical friendship, and we really appreciate having you guys along for the ride.
If you would like to leave comments, please do so on Justin's fantastic YouTube channel, because we all know that YouTube is the place to leave controversial comments and have a go at people. So jump on.
No, that is true. Don't email. Negative comments are good on YouTube. So if you want to leave negative comments anywhere, do it on YouTube. I'm happy with that. That's fine. Any interaction is good. YouTube loves strife and negative comments. That's good.
Cool. Go to First 10 NEM on the YouTube channel and check it out. All right. See you, mate. We'll chat in a couple of weeks.
Pleasure, buddy.
And if you want to see some serious dermatology in the meantime, Justin will have pictures up on the First 10 NEM blog site. And you can look up DermNet if you don't know what he's talking about. All right. See ya.
Take care, buddy.